we're going to jump into kind of our last section, which is just post-operative pearls. And I thought what would be nice is maybe just to talk through first sort of what does a normal post-operative period look like for a standard cataract patient who's doing a monofocal implant and looking to be back in glasses when all is said and done. And what is and then we'll maybe jump into some of the refractive cataract differences between diffractive multifocal or LAL. But maybe Tanner, I'm going to let you take a swing. Standard monofocal implant, going back to Dr. Ferguson somewhere out there in the world to get into a new pair of glasses after surgery. What does the post-operative period look like for that patient?
Sorry, I missed the first part of the question. We're just walking through the post-operative phase of a patient that has a monofocal?
Yeah. Yep, standard monofocal, both in terms of, what's a day, a week, a month going to look like and what should they expect?
Sure. So we, as we discussed before, over 90% of our patients have surgery on back-to-back days. And there's a lot of benefits to that, including, kind of the eyes healing in sync, and then the patient adapting to their kind of new optical system we've introduced into their eyes together, which I think is really helpful for adapting to some of these lenses. And so for a monofocal, we like to see them at 1 day, 1 week, and 1 month. It's normal to have some swelling in the cornea on 1 day after surgery, even more so if the cataract was more dense or a little bit of a longer case. But by a week, patients should be seeing really well. And if not, then it's even 1 week. It's not too early to look for other reasons for why the vision's not where it should be. And then we like to see them again at 1 month. And at the 3 to 4 week time point is when you can start to discuss with the patient about updating the refraction in their glasses.
Perfect.
Things I think, to look out for are, if the patient's complaining of, all of a sudden at 1 week, increased sensitivity to light or their vision's gone down. Those are concerning signs. You should have the patient come in to be seen. And then on exam, looking for increased signs of inflammation. I think in that like 5 to 10 day range is when you are most concerned about something like, an infection. But those can be seen as early as 3 days after surgery. But I think at the 1 week point, you really learn a lot about where the patient's going to go surgery-wise.
Beautiful. Brandon, can you maybe just differentiate somebody who had a extended depth of focus or diffractive trifocal lens? All those same things still apply, but now we're getting to that 1 month mark and maybe they have 0.75 diopters of astigmatism left. How's their journey going to be a little different than a patient with a monofocal implant?
Yeah, I think that, folks with monofocals are usually told, you're going to get certainly better quality vision by doing this cataract surgery. But if you have meaningful amounts of astigmatism, you can plan on being in glasses again most of your life after surgery. And those get prescribed commonly, 3 to 4 weeks out, right? As Tanner had said, with an advanced optic, these are patients that are expecting to not have to wear glasses, right? And, while many people with a certainly extended depth of focus and even in trifocal lenses can tolerate, up to that 0.75 or 1 diopter of astigmatism untreated and still do quite well, there may be those that start saying, boy, I'm not seeing as well as I felt like I should. And so if those patients are back in, your office and they've got that little residual astigmatism, you can start talking to them about, what's the plan to address it, right? Because there needs to be a plan to address any residual prescription after cataract surgery, monofocal or not. Monofocal, the glasses are a given. With an advanced optic, it's either, as Keith had alluded to before, maybe they're okay in a single vision lens pair of glasses and can have that treated at a month. But maybe there's somebody who says, well, I really want to be free as I can, and what's the plan for a touch-up? They may need a temporary pair of glasses and getting them to about a 3-month mark, right? So that's when the 3 months mark is usually when we start thinking about doing a fine tune, in which case we will commonly do an extra visit after the 3-month mark called an advanced visual analysis, where we really look at their tear film, their refraction to make sure everything else is healthy. identify their source of refractive error, and then go ahead and treat it with something like a corneal adjustment procedure, fine tune like LASIK or PRK. But that 1 month mark can be really important in touching base with those patients, letting them know, hey, you're still in the middle of this process, right? If you've got a little residual prescription, that's okay, right? There are plans to address that. If you need a temporary pair of glasses, that can be available. And then always reminding them that even once that refractive error is eliminated, things like dry eye are important to treat. Things like neuroadaptation are still taking place, and it can take months, even up to a year for patients to adjust to that. So setting the tone of those things, which also need to happen preoperatively, are important to remind patients in that early postoperative period.
Beautiful. Keith, maybe I'll throw it to you. You know, the majority of our patients are on what we would kind of term a drop a day program after surgery. Can you kind of talk through the postoperative inflammation control in terms of our use of intracameral medications and then topical medications after surgery, and kind of why we do it the way that we do?
Yeah, so back in the day when I was first started, it was 3 different drops. It was antibiotic 4 times a day for a week, and steroid 4 times a day for a week, 3 times a day for a week, twice a day for a week, once a day for a week, and then whichever NSAID. I mean, that could have been 3 times a day for a month. I mean, that was 10 to 12 drops for the first couple of weeks, and it's tough for patients. It was a big pain point. It was expensive. And then, probably maybe Russell, were you the one that started this, or was it even before you, where we started going to intracameral and
yeah, we were when I was a
fellow.
fellow there, we had just switched to intravitreal triamcinolone moxifloxacin and creating
Okay.
floaters for everyone. And then
Yeah.
at my end of my fellowship, we switched to dexmoxyketorolac, which was a very nice transition.
Yeah, good job, Russell. But boy, that has been such a game changer. It's amazing how quiet eyes come back at day 1. Certainly there's still obviously sometimes some edema, but it is so different, you guys, looking at 1 days now compared to 15 or 20 years ago. They're so quiet. Patients love it. Just using 1 drop a day. Risk of infections so small at this point. Compliance is through the roof, and it's just more cost effective for patients too. So it has been almost equally as big of a change as some of the advances in advanced implants. This has been huge for patients.
Yeah. I think about like the patient experience part of things, and there's all these places
Yes.
where that comes into play. IV free sedation, see and do, same day, next day. But drop a day has just been awesome for patients. And to take all 3 of those medicines, put it in 1 dropper, and they just know, hey, you gotta do it once a day. You can do it at the beginning of the day, the end of the day, middle of the day, whenever in the day, but you just got to get it in once a day. Tanner, I'd be curious. You sometimes some of our other conferences or in other communities, you'll hear about dropless surgery, and I'd just be curious. So, giving patients antibiotic and steroid at the time of surgery, and then nothing from a drop perspective afterwards. Boy, that sounds great. Maybe are you doing that at all? And if not, why not? Or what things kind of give you pause maybe about that?
Sure. So there's a number of different kind of approaches for dropless cataract surgery. The one is like a transonular injection into the anterior vitreous at the time of surgery. And there's benefits to that. And then the other common approaches they've talked about is, in addition to a intracameral or intraocular injection at the time of surgery, is like a intracanalicular punctal plug. That's like a drug-eluting implant. And then there's also another intravitreal injection that people are using. These all have really nice theoretical benefits, not having to take drops after surgery, avoiding, the ocular surface. But I think, we trialed some dropless approaches in our practice. I wasn't here during that time, but I think what people found was that there was more AC reaction they'd like, at day 7 to 10. And not adequately controlling inflammation can lead to, undesired consequences like CME, and then you're battling that. And so it can kind of just delay the healing process for patients. There are some places out there that are having success with this, but I think the results overall are mixed from an evidence-based standpoint. And I think the way we do drop a day coupled with back-to-back surgery where really they're only taking the drop for 4 weeks, I think is really a great thing for patients. And I feel more comfortable as a surgeon knowing that they're getting some anti-inflammatory continuously from, days 1 to 7 in that early postoperative period.
Yeah, I know for me personally, and Brandon, I'd love your thoughts too as we close out. But for me personally, I've lived through some of those trials of different things, and because it's kind of a dream state to be able to apply medicine, do at the time of surgery, and then not even have to have drops. And I'm still hopeful we'll get to a point where it's really consistent. But to your point, Tanner, kind of what I would term a higher than desirable rate of recurrent iritis, a
Right.
higher than desirable rate of cystoid macular edema. And then I think the other technique that you didn't describe that was commonly used and still sometimes is subtenon's Kinalog injection, which actually gives a nice prolonged
yeah.
anti-inflammatory effect. But particularly in concurrent glaucoma patients and or not, there is just a little higher risk of steroid-induced ocular hypertension. And that can be challenging to treat if somebody responds to that. And the nice part about having a drop is, again, incredibly rare to see steroid-induced ocular hypertension at once a day. But if we ever did, we can pull it off. And it's if you've injected subtenon's Kinalog or if you've injected intravitreal implant, that becomes a little bit more challenging to monitor. So for those reasons, for me, I like the drop-a-day program as it currently stands, and I'm still hopeful we'll find a nice alternative. But Brandon, your thoughts on that?
No objection, Your Honor.
I love it.
I agree.
Well,
I agree with everything you guys just said.
Awesome. But so maybe just in closeout, I'd just be curious because we're kind of getting towards the end of our time. Just any closing thoughts that you guys would like to offer to those people who might be listening in about anything in the world of refractive cataract surgery before we sign off today?
I think the main thing is it's and always has been, but it's becoming more and more of a refractive surgery. And so we want to kind of start shifting our mind from just taking care of cataracts to helping our patients see like they want to see after surgery. And whether it's with glasses or without glasses, whether they want to stay myopic or go for, more distance vision, understanding our patients' needs, meeting them where they're at, educating them. I love how Brandon said education and time. I mean, when you said that, I just see patients all the time just relaxing when they have education and time. And so just meeting our patients where they need to be and thinking of cataract surgery from a refractive standpoint, I think is, key in these cases.
I would say listening to your patient. They'll tell you
Yep.
what's going to make them happy after surgery.
Yep.
It's easy for us to say, no, you don't want to stay a -3.5. But I will tell you from personal experience, I took care of a patient this week who had cataract surgery elsewhere, who gave her a -2, thinking, well, that's what traditionally we do when somebody wants to be myopic after surgery. But she wasn't happy, right? And so we had to go in her fellow eye. She was so scared to have her fellow eye done. We went to a -3.5, right? Because she said, this is where I want to be. And she was thrilled, over the moon. And so listen to your patients. They will tell you what is going to make them happy.
Yep.
The only thing I add is kind of on that patient education piece. I think we talked a lot about time, and I think, we've come up with some things or adopted some technologies that help with this, but I think timely delivery of information to patients and continuing to provide information along the journey is super important. We give all this information to patient before their surgery and then on the day of their evaluation. But I think continuing to provide these patients with information along their journey is super important and help them get into a good place.
Beautiful. I love it. Well, to all three of you guys, thanks for jumping on. Tanner, Brandon, Keith, super appreciate it. A couple of just closing thoughts just from myself. A reminder, if there's any of you guys that are out there that maybe are early in training or just haven't seen a lot of post-operative cataract patients or would really like to kind of listen in on, hey, how do I talk to patients about refractive cataract surgery? We do a lot of hands-on learning. We have in-person kind of mini fellowships at all of our sites. And certainly if that's something that's of interest to come spend a day and kind of observe those conversations, observe that patient experience, we'd be more than willing to have you join us for that. So remember, the world of eye care, it's ever changing. So are we. We're super excited that you joined us. And until next time, we're signing off and have a great day.